Hello, my name is Nikki Mendoza, and I'm going to talk today about methamphetamine use. Methamphetamine is a synthetic and highly addictive psychostimulant. Sometimes you may hear it called meth, crystal meth, speed, crank, or ice. It can be powder, pill, or crystal form. It can be smoked, injected, snorted, or taken orally. And as we will see, it causes many harmful short and long-term effects. The history of meth use is actually pretty interesting in the United States. It was first synthesized by a Japanese chemist in 1893 as an alternative to the ephedra plant. The ephedra plant has been used in Chinese medicine for over 5,000 years as a stimulant. This process of synthesizing it was streamlined around 1919, and this is when it began to be used as medication, as treatment for things like narcolepsy, weight loss, and asthma. In World War II, amphetamines were used by soldiers on all sides of the war to help keep them awake and alert and suppress their appetites. During the 1960s, the late 1960s, young adults were experimenting with drugs, including amphetamines. And around this time, people started to inject meth, and there were many associated medical and psychiatric problems. And so because of that, in 1970, there was the Comprehensive Drug Abuse Prevention and Control Act, and this put really strict limits on the medical uses for prescribed amphetamines. So this temporarily decreased the problem of meth use in the United States. For most of the 70s, it was really just sort of concentrated to these areas, these really specific areas in the West with these motorcycle gangs in California and Oregon. They continued to make and use meth. The interesting side note, they would carry the meth in the crankcases of their motorcycles, which is where the slang term crank comes from. In the 80s, the meth from Asia started to come over into Hawaii in a different form. It was in a crystallized form that could be inhaled called ice. So this was a lot stronger. And then in the 90s, there was a huge expansion in the 90s. And this was due to the proliferation of these mom and pop home labs, along with the proliferation of large super labs in Southern California and Northern Mexico. So because there was so much more product, it went down in price, and so people began to use it more. Another interesting note, a lot of these mom and pop home labs are located in rural areas, and because when you make meth, it creates a strong odor that would be detected, more likely to be detected in a city or a suburban area. So that's why so many of these labs are in rural areas. So major expansion in the 90s up until 2005. And what happened in 2005 was the Combat Methamphetamines Epidemic Act. And what this did is this regulated pseudoephedrine sales. I think probably most people know about this. When you go to the pharmacy and you go to buy any product that has pseudoephedrine in it, sometimes you have to show your ID or you have to sign a logbook. Oftentimes it's not even available out in the aisles. They keep it behind the counter. And this is because pseudoephedrine is one of the main ingredients in these mom and pop home labs making meth. So because of this, again, we see a decrease in the production. This led to increased prices and decreased use from about 2005 to 2010. But unfortunately, the decreased use in production here in the United States was replaced by increased production in Mexico, and it was a higher purity form of meth. And so from about 2011 on, use has been increasing again. So that brings us to present day. The most recent data is from 2023. Among people 12 and older, 0.9% of the population, so about 2.6 million people, used methamphetamine, and 0.6%, or about 1.8 million people, had a methamphetamine use disorder in the past year. Another more recent statistic, between 2013 and 2019, drug overdose death rates involving psychostimulants increased more than 300%, and the percentage of deaths from overdose involving psychostimulants rose from 8.2 to 22.9%. And what's concerning about that statistic is that a lot of these deaths are from people in geographic regions where meth traditionally wasn't an issue before, so places like the Northeast, and then in demographic groups that traditionally had low rates of meth usage, like non-Hispanic Black folks. So this, I think, is an interesting map. This shows the top 10 cities with the most methamphetamine use as a percentage of the population. Knowing the history, this makes sense that because most of the meth is coming from Mexico now, that it would be these southwestern cities that have high meth use. Although, as I mentioned, there's not really anywhere in the United States anymore that hasn't been touched by it. These are the places that have the highest use. So risk factors in vulnerable populations. Past year meth use was associated with male sex, being 26 years of age or older, lower educational attainment, annual household income less than $50,000, Medicaid only or no health insurance, and then residing in a small metro or non-metro county. And then vulnerable populations are men who have sex with men. This is because meth is frequently used in a sexual context with this group, and then this further increases their risk for STIs, including HIV. Women, so especially young women, some young women will use meth in order to lose weight. Those who misuse opioids, sometimes this is intentional, in the sense that when a person who is misusing opioids can't get opioids, sometimes they will use meth instead. Sometimes they have the mistaken assumption that it's safer to use meth, which is not necessarily true. Sometimes they're not purposely doing this, it's just that the opioids can be contaminated with meth and vice versa. And then Black men. So between 2011 and 2018, Black men had the fastest increase in psychostimulant involved overdose death rates among men. So as I mentioned in the previous slide, unfortunately, we're starting to see meth use in groups of people where we traditionally had not before. So short-term effects, the big one, the reason why people do this is euphoria. It tends to be pretty swift and strong, but it can wear off quickly too. And so some people will take it repeatedly to avoid a crash or a come down, and this increases the risk of addiction. If it is injected or smoked, that euphoria is immediate. Otherwise, it can take up to 20 minutes. Other short-term effects would be increased energy, alertness, confidence, and sex drive, decreased appetite, and then some unpleasant short-term effects and risks would be anxiety, paranoia, arrhythmias, tachycardia, stroke, hypertension, kidney damage, and overdose. Long-term effects and risks would be increased risk of developing substance use disorder, increased risk of developing things like psychosis, depression, anxiety, insomnia, decreased cognitive function, particularly memory issues, stroke, and they are particularly hemorrhagic stroke, heart failure, heart attack, infective endocarditis, kidney disease, HIV, hepatitis, other STIs, tooth loss and tooth decay, decreased sexual function in men, overdose, and death. So signs and symptoms of abuse, if a patient is coming to you and they are using meth, these are things you might see or notice. Things like mood swings, paranoia, and hallucinations. And the big thing to note here is that a lot of the times the hallucinations are tactile hallucinations. So they call it formication, which means to crawl like an ant. So this is where the patient will think that there are bugs under their skin. Sometimes they call this crank bugs, meth mites, or ice bugs. And so the sensation that bugs are crawling under their skin causes them to itch and tear their skin, which is why you will sometimes see the next thing, which is sores and scabs on their skin. You may notice them picking up their hair in their skin. Other signs and symptoms include psychomotor agitation, rapid speech, tooth decay, disordered sleep, decreased need for sleep, decreased appetite, and marked weight loss, burn marks on the fingers and the mouth, The patient may be malodorous, almost having an ammonia-type smell to them, dilated pupils, excessive sweating, uh, muscle twitching, facial tics, jaw clenching, and teeth grinding. Tweaking. Tweaking is a slang term for these obsessive and repetitive behaviors that patients will have, sometimes for hours, doing things like picking at their skin, cleaning, taking things apart, and putting them back together again. Overdose and suicide potential. Methamphetamine is very dangerous with a high overdose and suicide potential. It's second only to synthetic opioids with regards to deaths from overdose. Death can result from short-term or chronic use. Most people who die from methamphetamine use actually aren't included in overdose data because it is more from the problems related to chronic use. But overdose can cause tachycardia, arrhythmias, hypertension, hyperthermia, seizures, stroke, and MIs. As I have mentioned in a previous slide, it is commonly used alongside opioids, both intentionally and unintentionally, and this will increase the risk of overdose and death. And unlike opioids, there is no Narcan for methamphetamine. So when someone has overdosed on methamphetamine, you're mainly trying to treat the symptoms to help them. So a care plan for a patient who is using methamphetamine from a pharmacologic standpoint. Unfortunately, there are no current FDA-approved treatments, but there are several experimental trials. So naltrexone as a long-term injectable and a long-acting bupropion together. There are some studies that have shown decreased levels of meth use at the 6-week and 12-week mark when people were being treated with that. There is also an ongoing study right now at UCLA using injectable buprenorphine. Now, this is for people who are using opioids along with the meth, but that is a fair amount of people that do that. And then there are lots of, small studies that show some promising results of using things like prescription psychostimulants, and then medications like topiramate and mirtazapine. Again, nothing FDA approved yet. We need more studies on all of this, but there's some promise there. The treatment that has the most evidence to support it is a non-pharmacologic treatment called contingency management. So contingency management is a behavioral treatment, and it's based on principles of positive reinforcement, and this is where the patients are given some sort of reward for abstaining from using meth. So this might look like a gift card when they have a clean urine sample. There is, like I said, a lot of very strong evidence supporting this, but it is hard to implement. The biggest reason why is that there is a limit of $75 per participant for any CM program that's using federal funds, and that includes grant money. And the studies that have been done showing that this is effective have shown that you need about $200 to $300 a month for 3 to 6 months in order to reduce meth use and then increase recovery behaviors. So that has made things difficult. Something else that has some evidence showing its effectiveness is called community reinforcement approach. And this is sort of a multi-pronged approach that uses functional analysis, coping skills training, and then social, familial, recreational, and vocational reinforcements. Cognitive behavioral therapy has been proven helpful with other substance use disorders, but the data is pretty limited on its effectiveness specifically with stimulants. And we're not sure if this is because there haven't been very many big, well-done studies, or for whatever reason, it just doesn't work as well when it comes to stimulants. As far as patient education, educating the patient on the nature of the illness, the fact that addiction is a chronic disease, and getting into a little bit of what I mentioned earlier about, what happens with the body, the short-term and long-term risks, different treatment options, and then safety planning. I think it's always a good idea when doing patient education to use some little motivational interviewing techniques to sort of find out where they are as far as how much education they would be open to receiving, and then kind of go from there. Referral wise, there are many different sort of intensity of treatment programs. There are outpatient, intensive outpatient, residential, and inpatient treatment programs. So, depending on your patient and what is going on with them, you can refer them to the appropriate level of care. And then for follow up, addiction is a chronic illness. So, patients shouldn't think of this as something that they'll be cured of, but rather a condition to be managed. So, it will, ideally, they will have follow up. Now, what that will look like will be individualized based on the patient's needs, but in order to be successful in staying in recovery, patients will need continued follow up for sure. So, in conclusion, methamphetamine is highly addictive with many harmful short and long term effects. Methamphetamine has gone through many cycles in the United States. We are currently experiencing high levels of use due to increased potency, affordability, and availability. The good news is that some of the damage that is done to the brain from meth use, both structural and chemical, can actually be reversed once a patient is in recovery. So even though we don't have FDA approved medications, and even though the best non-pharmacological approaches that we have may not be easy to access, we do still have some tools at our disposal. And it is imperative that when we encounter patients who are struggling with meth use and addiction, that we're able to get them the help that they need. And these are my references. Thank you.